next subject which we are going to start, pathology. Now pathology, first of all, general pathology will be talking about. In the general pathology, we'll be talking about the cell adaptation. What is hypertrophy? Increase in cell size. What is hyperplasia? That is increase in cell number. Where they happen, physiological, pathological, let it be as of now for a revision. Just if you know, that is fine. Okay. Now atrophy is decrease in cell size and number, my dear friends. Atrophy is decrease in cell size and number. And metaplasia is normal cell replaced by another normal cell. Like squamous is replaced by columnar, columnar is replaced by squamous. So best example is squamous metaplasia, which is seen in the smokers. So your columnar cells in the lungs are replaced by squamous because of lot of sutta sir. Lot of sutabaji will lead to this. Then columnar metaplasia, another example. Squamous metaplasia, cigarette पीने वालों का lungs के अंदर हो रहा है. This is columnar metaplasia. Sir, we will see this in the Barrett's esophagus. Now, sir, squamous is replaced by columnar in the Barrett's esophagus. The esophageal lining, upper 2/3 is the squamous lining. यहाँ पे जब metaplasia होता था, intestinal columnar cells are replacing them. And what is a hallmark? Hallmark are what, sir? Your goblet cell. Goblet cell. And which stain we use? Alcian blue and muciramine stain we use right here, sir. Coming on to the cell injury part. What is reversible cell injury? What is irreversible cell injury, my dear friend? Now, reversible cell injury, the earliest ion involved is sodium. And the macrophages, most important part you are going to see is the swelling. And this is called as pycnosis. Only pycnosis. If karyorrhexis, karyolysis is going to happen, that means this is irreversible. If the earliest ion involvement is calcium, that means this is irreversible. Myelin figures are seen, that means this is irreversible. And large amorphous densities are also seen, that means also this is irreversible. So you'll see a pycnosis, karyorrhexis, karyolysis, which you are going to see on the light microscopy. The earliest ion sodium, only pycnosis will suggest you of a reversible cell injury. Earliest ion is calcium, myelin figure, large amorphous densities, pycnosis, karyorrhexis, karyolysis. That is going to tell you this is an irreversible cell injury. That will tell you this is an irreversible cell injury. Now what is oxidative stress? Sir, the free radicals, if they are going to increase, they are going to do the oxidative stress. And the most potent free radical is again MCQ I'm going to highlight, that is hydroxyl radical, my dear friends. Now what are the consequences of the free radical injury? There will be a protein misfolding, damage to the DNA will happen, and now the normal part of the brain which is protected by, and that is by the SOD1 gene, superoxide dismutase. And if this gene is getting mutated, there will be a free radical injury to the brain, there will be oxidative stress to the brain, and there will be irreversible injury to the brain. This is how you will learn, my dear friends. Now coming to the cell death part, sir. Cell death part, sir. Cell death part. Cell death part number 1 is necrosis. What is necrosis? Necrosis is inflammation present. Cell death is happening. First of all, cell death is happening and always pathological. We compare this with the apoptosis. Apoptosis can be pathological, can be physiological, sir. These are the small minute details. If you will revise it, give you boost, and you will puke it out in the exam and you will pass it. Done. Inflammation is present. Okay, done. Denaturation of a protein and enzyme on digestion is seen, that in the cell you will see. Now what are the different type of necrosis? This is something which is very important for your exam. This is what we are going to discuss right here. So number 1 type of necrosis we are going to discuss right here is a coagulative necrosis. A coagulative necrosis, a most common type of necrosis. Number 1, organs, solid organs like heart, spleen, kidney is included, but not the brain, because in the brain you will see a liquefactive necrosis, my dear friends. Liquid. You will see right here the dry gangrene. So dry gangrene is coagulative, seen in the solid organs except brain. In brain you will see the liquefactive necrosis. Liquefactive necrosis, my dear friend. Now third type of necrosis is going to be the caseous necrosis, which is seen in TB, syphilis, histoplasmosis. Here you will see a cheese-like appearance. Sir, we just not stop here. There's a 4th type of necrosis, 5th type of necrosis. What are those? Those are the fat necrosis, fatty necrosis. A chalky white deposits are seen. Where they are seen? PBOM. P for pancreas, B for breast, O for omentum and mesentery. This question I have seen in the exam, myself has seen in the exam. So my dear friends, this is your pancreas, omentum, mesentery and breast. Here you will see a fat necrosis where the chalky white deposits are seen. You can very well appreciate in this image also right next to me, sir. Now coming to the next one, sir. Next is fibrinoid necrosis. It is seen associated with type 2 and type 3 hypersensitivity. Separately, we are going to talk about the type 1, type 2 and type 3, type 4, type 5 hypersensitivity. Now, you will see this is seen in the vessel wall. You will see the fibrin-like deposit. This is a blood vessel and here you will be having a surrounding fibrin-like appearance. This is called as fibrinoid necrosis. This is called as what, sir? Fibrinoid necrosis. Now, diagnosis. On the gel electrophoresis study, how you are going to diagnose? This is also your previous year topics, sir. Never forget these simple topics which are going to help you passing this exam. इन सवालों में गलती करना allowed नहीं है. It's okay, we forget, everyone forget, सबको भूल जाता है. For that, yesterday also I was telling that make small flashcards. भूलने वाली कैटेगरी में ये देखिए कि ये एग्जाम में आने वाला है कि नहीं. अगर ये एग्जाम में आने वाला है और फिर भी भूल रहा है, for that make small cards. For that make small card. See them 10-20 times, at least 50% of the things you will able to recall. Or ask your friend to read it for you. Maybe he read and you can understand well. Any of the way you can do it. Maybe if you are sitting at your home and you have no one, you can make the cards, forward it to your friend and call them and tell them to tell the points written in that. This is a way. अगर सीधे रास्ते से काम नहीं हो रहा तो रास्ता टेढ़ा करो, बट जाना वही है. दैट इज द अल्टीमेट गोल. वी ऑल हैव टू रीच देयर. पढ़ के ही जाना है. खुद से पढ़ रहा नहीं समझ आ रहा है, आस्क योर फ्रेंड टू हेल्प. अब ये नहीं पूरी किताब लेके बैठ के पूरा पढ़ा दे. नो, इस सेलेक्टिव एरिया वेयर यू आर फाइंडिंग अ डिफिकल्टी, आस्क योर फ्रेंड टू हेल्प एंड यू विल गेट अ हेल्प एंड हेल्प देम टू. यू पास, मेक देम पास, मे एवरीवन पास. चलो. Now coming on to this direct electrophoresis study, if you are going to see the smearing pattern, this is necrosis. If you are going to see step ladder pattern, this is going to be the apoptosis. This is going to be the apoptosis. Now apoptosis, necrosis is done, sir. Inflammation was present, sir. Here in the apoptosis, the inflammation is absent. Yes, the inflammation is absent, sir. In the apoptosis, the inflammation is absent. The earliest feature is cell shrink and most characteristic is chromatin condensation. You can see the apoptotic bodies. Apoptotic bodies. Okay? This is programmed cell death. And this can be physiological, can be pathological. But if I compare this with necrosis, necrosis is always and always pathological. Necrosis is always and always pathological, sir. Done? Now, apoptotic bodies are seen. We have seen right here. Enzyme involved in the apoptosis. So remember, here is a caspase and endonuclease. This endonuclease is responsible for step ladder pattern, what we have seen right here, sir. Question mark, sir. Next is caspase. It is an initiator and executioner. Ini में क्या आता है? 9. Ini 9. Before night it comes 8. After 9 what comes? It comes 10. The ini is 9, 8, 9, 10. Executioner is 3, 6, 7, my dear friends. Now factors in the apoptosis, very important. Apoptosis. Pro-apoptotic, anti-apoptotic and apoptotic sensor. Shout out along with me and you are able to learn it right now, sir. Backs and back, they are pro-apoptotic. Backs and back, this is pro-apoptotic. Anti-apoptotic के अंदर सबके अंदर LL आ रहा है, ठीक है? तो this is BCL2, BCLXL and MCL1. Now sensor, BIM, BID, BAD, noxa, puma. एक slang बना हुआ है. BIM, BID, BAD, noxa, puma. BIM, BID, BAD, noxa, puma. BIM, BID, BAD, noxa, puma. So BIM, BID, BAD, noxa, puma is a sensor, apoptotic sensor. Anti-apoptotic, pro-apoptotic, apoptotic sensor. Done, done, done. Now coming to the third term. Apoptosis done, necrosis done, comfortably done. This is necroptosis. Now there is a mixture of two things. What are those two things, sir? One is necrosis, another is apoptosis. Necrosis, apoptosis मिल जाते हैं. The question comes in the Q bank I've seen. Is this caspase dependent or independent? अब तो इसके अंदर apoptosis है. Apoptosis तो caspase dependent होता है, sir. तो अगर ये मिल जाता है तो होता है. Answer is no. This is caspase independent. Necroptosis is your caspase independent. Caspase independent. Now fourth one, pyroptosis. आग लग गई, बुखार आ गया. Fever and inflammation is happening. So we have learned about the necrosis, apoptosis, pyroptosis and necroptosis. Now calcification, two type of calcification if we focus right here, my dear friends. One is dystrophic, another is metastatic. D for dystrophic, D for dead tissue. Yes, metastasis उसी में होगी जो जिंदा होगा. So this is seen in the living tissue. And once the question was asked, my dear friend, dystrophic calcification, the serum calcium levels are normal. मरे हुए में क्या ही होगा? Normal. Metastatic के अंदर serum calcium levels are high. This is how we will differentiate between the dystrophic and metastatic calcification. Dystrophic and metastatic calcification, my dear friends. Now what are the pigments? Two pigments you will understand, exogenous and endogenous. Exogenous is a carbon that is tattooing. Endogenous pigment is melanin, hemosiderin, lipofuscin. This lipofuscin is also called as wear and tear pigment. This is also called as wear and tear pigment. Wear and tear pigment. Done, done, done. Now let's talk about the next part, that is inflammation. The inflammation can be subdivided into acute and chronic. Acute and chronic. Acute and chronic. Okay? Now acute is having short duration, and the cells which are coming in the acute one is a neutrophil cell. Neutrophil cell. Chronic is long duration, and inflammatory cell which are coming long duration, monocyte, lymphocyte, macrophages. Now how this acute and chronic is going to be having a proper flow chart, I'm going to tell you. Okay? I'm going to tell you. Now coming to the cardinal signs of inflammation, this is also previous year topic for your exam. This came in your exam. Rubor, tumor, dollar, calor, functionalia. What are those five cardinal sign of inflammation? This tells that there is inflammation. अगर ये present होगे तो inflammation होगा. इनके बड़े fancy से नाम है rubor, tumor, dollar, calor, functionalia. Now what are they? Rubor is रगड़ोगे तो redness, calories, heat, dollar खो जाएंगे, pain होगा, tumor के साथ swelling, functionalia मतलब loss of function. Now first four, rubor, calor, dollar and tumor, they are given by Celsus. And fifth one, which is functionalia, given by Virchow. This was also your exam question. This was also your exam question, my dear friends. Now coming to the acute inflammation events, I'm going to explain you acute inflammation ke events, and these are equally important for the exam. So my dear ladies and gentlemen, please focus on the screen right now, sir. So you will see the vascular event and cellular event. We have divided this event into vascular and cellular. So let's see what happens in the vessels first, then what happens in the cellular first. There will be a transient, when there is an inflammation, transient vasoconstriction will happen. After that vasodilation will happen. Now vasodilation के साथ में आपकी vascular permeability will increase, then stasis and then migration of cells will happen. Now let's talk about the cells. ठीक है, बड़ा simple सा logic दिया कि भाई पहले transient vasoconstriction हुई, उसके बाद vessels dilate हुए, permeability बढ़ी, cell stasis हुआ, migration of cells started. Now cellular event. First of all, there will be what, sir? Margination. Before rolling, what will happen, sir? Margination. Margination will happen. After that, what will happen, sir? Rolling will happen. And who are helpful in rolling? E-selectin, P-selectin. Selective people can roll. E or P-selectin. Then coming to the adhesion. Roll होने के बाद वो चिपक गया. I-CAM, V-CAM. I-CAM, V-CAM चिपका देते हैं. Then transmigration. अब चिपकने के बाद उससे बाहर निकल रहा है. That is PE-CAM and CD31. PE-CAM1 and CD31. Now coming to the chemotaxis. Chemotaxis agents are there. They'll attract them. C5a, LTB4 and interleukin 8. Three names are equally important. What are those? C5a, LTB4 and interleukin 8. And interleukin 8, sir. Interleukin 8. Then opsonization. What is opsonization? They are coated so that phagocytosis can happen. So what are opsonizing agent? Which are the opsonizing agent we are having, sir? Opsonizing agents are C3b, 4b, 5b. Okay? And IgG. Hemoglobin, antibody IgG. So remember what do? They do the phagocytosis. So these are the vascular event. These are the cellular event. 1 marks MCQ comes from this table only, sir. This table only. I hope you all understood. And let's move on to the now giant cells. Giant cells. Okay? First giant cell we have to talk about Langerhans giant cell. They are seen in the TB. Okay? Ashkoff giant cells, they are seen in rheumatic heart disease. One-liners you have to remember for your exam no matter what. Reed-Steinberg cell, they are seen in the Hodgkin's lymphoma. And Warthin-Finkelday giant cell, if you see, they will seen in the measles. Asteroid bodies, these are Reed-Steinberg cells, sir. This is Langerhans giant cell, sir. Ashkoff body का image नहीं है. Just remember, no image is there. Warthin-Finkeldy giant cells are here, sir. This is asteroid body you will see in the sarcoidosis. Also Schumann bodies are seen in the sarcoidosis. So sarcoidosis are two type of bodies you will see. Schumann bodies and asteroid bodies. Schumann's and asteroid bodies, they are seen in the sarcoidosis. Coming on to who is doing what. So important one-liners, we have to read it here. Histamine and platelet activating, they are doing the vasodilation. Serotonin, they are doing the vasoconstriction. Nitric oxide, vasodilation. Thromboxane A2, remember, they are doing the vasoconstriction. And moment they are doing the vasoconstriction, the platelet aggregation start. Opposite to this, prostaglandin I2 is there. So thromboxane A2 and prostaglandin I2 is important. Sir, thromboxane A2 will do the vasoconstriction. तो vessels constrict हुई, platelet पास में आए. Prostaglandin I2 dilate करा, platelet दूर दूर चले गए. E2 is for fever and pain. Strongest potent is LTC4. MAC complex was once asked question in 2020 December exam. This MAC complex is formed by all C5 components like C5, C6, C7, C8 and C9. They are forming this. Now what is the main difference between hypertrophic scar and keloid? So this is an important topic you need to revise for your exam. Hypertrophic scar, you will see the color will be approximately same as skin. Okay, and it can be present anywhere. If we check about the keloid is darker than the skin, and the favorite sites for the keloid is going to be the pinna, sternum and shoulder. What treatment you are going to offer in the hypertrophic scar? Local cream application you can apply. Keloid, you will give intrakeloidal injection of triamcinolone, done and dusted, sir. Now let's talk about the granulomas. First of all, caseating granuloma. The first granuloma which we have to talk about is caseating granuloma. This is seen in TB, syphilis and histoplasm. Like caseous necrosis, this is caseous granuloma. Non-caseating granuloma, where you will see non-caseating, it is seen in the sarcoidosis. It is seen in the sarcoidosis. Palisading Wagner's granulomatosis. Palisading granuloma, you will see a palisading pattern right here, like a seashore pattern. And stellate granuloma, you are going to see in the cat scratch disease. Cat scratch disease. Coming on the type of hypersensitivities, my dear friends. Type 1 is for allergy, like asthma. Type 2 is B, alphabet B, that is blood related. That is my blood group is Rh positive. That is myasthenia gravis, blood transfusion, good pasture syndrome, immune ITP, that immune thrombocytopenic purpura, Rh incompatibility and pernicious anemia. Then type 3 is immune complex mediated, that is type C alphabet is coming right here. Example is sharp, that is SLE, Hinoch-Schönlein purpura, arthritis reaction, rheumatoid arthritis, polyarthritis nodosa and type 2 lepra reaction. Now type 4, if we talk about, this is delayed and it includes type 1 lepra reaction, and type of graft is also important question for exam. My dear friends, remember type of graft: auto, iso, allo and xeno. Auto is a self graft, iso is an identical twin, allo is a same species and xeno is a different species. So auto, iso, allo and xeno type of graft you have to remember. Now there will be a hyperacute graft, acute graft and chronic graft rejections. This is also being asked these days. My dear friends, hyperacute within minute to hour, acute days to week and chronic month to year. So minutes to hour, days to week and month to year. This is how they are divided onto the duration part. Now beta cells, where they are produced in bone marrow and they get matured in bone marrow. Important question. Sir, beta cells are produced in B cells, not beta, it is B cells. B cells are produced in bone marrow, matured in bone marrow. T cells are produced in bone marrow but they get matured in thymus. Another previous year question. MHC1 and MHC2, where they are present? MHC1 is present at CD8, MHC2 is present at CD4. So you will see 1 into 8 is 8, 2 into 4 is 8. Total should be 8. If it is MHC1, it should be 8, CD8. If it is MHC2, it should be CD4. Then it is making in total 8, my dear friends. Coming on to the next part, type of cell. What type of cells we are having? Permanent, stable and labile. 3 type of cells we are having right here, sir. Permanent cells are non-dividing and they left the cell cycle. Permanent cells are non-dividing and they left the cell cycle. For example, inner hair cells, neurons. Okay. Now stable cell, they divide when it is needed. When they need it. Otherwise they don't, but they only divide when there is a need. And they are present in G0 phase of a cycle. Can you give me one example? of a stable cell. ठीक है. Now labile cells are rapidly dividing. They are in the G1 phase. Like epithelium cells are there. They are rapidly dividing cells. नया आएगा, पुराना जाएगा. Like this silsila is going on, my dear friends. Now let's talk about the repair part. Now repair part, there is a deposition or formation of granulation tissue, and hallmark of granulation is neovascularization. पहले आपको क्या होगा, ग्रैनुलेशन टिश्यू आएगा और ग्रैनुलेशन टिश्यू प्रेजेंट होगा, तेरा मतलब न्यूवैस्कुलराइजेशन हो रही है, वहाँ पे नई वेसल्स आ रही है, ग्रैनुलेशन टिश्यू आ रहा है, हील करके वो क्या कराएगा, वुंड को हील करेगा. नाउ कमिंग ऑन टू द थिंग इज, नाउ वुंड हीलिंग, प्राइमरी इंटेंशन एंड सेकेंडरी इंटेंशन. वुंड हीलिंग इफ यू टॉक अबाउट सर, primary intention, no loss of tissue and wound is clean. If you can see, this is primary intention healing, sir. Primary intention healing. Secondary intention healing is an infected wound healing where the tissue loss is also very much observed. Endometrium, yes, 𝗲𝗵𝗵𝗴𝗿𝗺, well example, good. Now important steps in the wound healing. What happens after the injury? Sir, first of all, there will be a blood clot. After that, the first cells coming are neutrophils. Now neutrophils के बाद में macrophages plus granulation tissue is coming. Granulation tissue आया तो neovascularization भी होगी, maximum collagen आएगा, and then there is a scar formation. A very simple, obvious, fundamental you have to apply right here. First of all, there will be a blood clot. Blood clot के बाद आएंगे neutrophil. Neutrophil will be replaced by macrophages क्योंकि बाद में acute inflammation का cell is neutrophil and chronic का macrophages. So neutrophil is replaced by macrophage. Macrophage is getting replaced along with the आपका granulation tissue. And what is the hallmark of granulation tissue? That I've taught you. The hallmark of granulation tissue is going to be your neovascularization. Once the neovascularization starts, maximum collagen comes, then there is a scar formation. Clean wound, no loss of tissue, primary healing. Unclean wound, loss of tissue, secondary intention healing. This is how you will remember. Done, dana, done. Chalo. Let's talk about the next thing is neoplasms. Next topic, what we are going to do is neoplasm. So my dear ladies and gentlemen, benign and malignant are the two parts where we are dividing it into. Sir, the benign part suffix come oma. Whenever oma is there, we call that as benign. But there are some exceptions where the malignancy, those end with the oma. They are ending with oma, but they are malignant. Melanoma, lymphoma, chloroplasma, seminoma. Melanoma, chloroplasma, lymphoma and seminoma. Now malignant, remember, suffix end with carcinoma and sarcoma. And they are having a property anaplasia. Benign के अंदर anaplasia. What do you mean by anaplasia? Anaplasia means loss of differentiation of the cell. Cell को differentiate नहीं कर पाते हो. अगर आप cell को differentiate कर पा रहे हो, that means this is a benign. If you are not able to differentiate a cell, that means this is malignant. So anaplasia is present in malignancy. Anaplasia is absent in benign. Metastasis is absent in benign. Metastasis is present in malignant. Okay. Now coming to the next part is exceptions in the malignancy. Malignancy that do not metastasize. ऐसी कौन सी malignancy है साहब जो metastasize नहीं करती है? So your first answer is basal cell carcinoma and glioma. Basal cell carcinoma and glioma. Where you see the basal cell carcinoma, sir? Glioma, you will see glioma multiforme. You will see in the brain. Okay, nice. But basal cell carcinoma, where you are going to see, my dear friends, you have to get the answer. Most common place where you see, and what is the other name of basal cell carcinoma? Now coming on to the pointer index of a squamous cell and adenocarcinoma, this has been also been asked in the exam. If you see the abnormal glands like this is adenocarcinoma. If you see the keratin pearls like this is going to be the squamous cell carcinoma. The pointer index, yes. The nose के ऊपर, yes, and this other name is rodent ulcer. Now coming to the most radiosensitive phase, radioresistance phase, cell cycle. We are going to talk about the cell cycle. The next topic, what we are going to talk about, sir, this is your cell cycle. So most radiosensitive phase is G2M. Most resistance phase is S phase. Radiosensitive cell is lymphocyte and resistance is platelet. Resistance is what, sir? Platelet. Very good. So sensitive is G2M. I'll ask some questions. Sir, most radioresistance phase is G2M. Most radiosensitive is G2M. Most resistance is S phase. Radiosensitive cell is lymphocyte. Resistance is platelet. The four answers are done. Now, what are the tumor suppressor genes and what tumor it is associated with? This chart is also very important and giving you 1 marks sure shot in your exam. For sure, in your GTs, in your exam, you are going to get from here. Okay? Chali. Tumor suppressor gene, if we talk about tumor suppressor gene, first is RB1 gene, where it is present chromosome number 13q14, 13q14. And which tumor we are going to talk about? If it is suppressed, then it is going to be the retinoblastoma. If it is not working, there is going to be retinoblastoma. In ophthalmology final aid, we are going to talk about this thing. Done. Welcome to the final aid on the Conceptual Medicine channel. Now BRCA1, BRCA2, BRCA1, BRCA2, they both are for breast cancer. Where they are present, BRCA1 is at 17, 2 is at 13 chromosome. Now BRCA is for the breast and ovarian cancer. BRCA1 is for breast and ovarian, BRCA2 is for breast and prostate cancer. Now neurofibromatous type 1, 17 chromosome, neurofibromatous type 2, 22 chromosome. This neurofibromatous type 1 will lead to neurofibromas, and neurofibromatous type 2, they will lead to Tumor. Vestibular Tumor, 8th nerve tumor it is. 8th nerve tumor it is. Now sir, WT suppressor gene 1 and 2, they will lead to Wilms tumor. VHL, clear cell carcinoma of the renal cell. STK11, it is going to have a Peutz-Jeghers syndrome. So my dear friends, remember these important genes and their tumor associated with. Shall I ask you some questions by hiding it right now, sir? Sir, neurofibromatous 1 is associated with. My another question is VHL. Von Hippel-Lindau, VHL is associated with clear cell cancer of a renal cell. STK11 is associated with Peutz-Jeghers syndrome. Important tumor markers. Now, important tumor marker. This is also going to give us 1 mark in the exam, sir. Important tumor markers, if we have to talk about, first is PSA. How much PSA should be? It will tell us prostate cancer, it is 10. If it is more than 4, it will tell us about the BPH, benign prostate hyperplasia. Now, calcitonin, medullary cancer of the thyroid. HCG, beta HCG we talk about, choriocarcinoma. Sir, alpha fetoprotein, hepatocellular carcinoma. CA19-9, 9 को उल्टा करो, it is looking like a P, pancreatic cancer. CA125 is ovarian cancer. 15-3 is a breast cancer. Catecholamine is for a pheochromocytoma. So all important tables you have to remember for your exam. These are the things you need to mug up again and again. So PSA, prostate cancer, calcitonin, medullary carcinoma of thyroid, HCG for choriocarcinoma, alpha fetoprotein, hepatocellular carcinoma, CA99 pancreas, 125 ovarian, 15-3 is breast, and catecholamine is pheochromocytoma. Done and dusted, sir. Now coming on to the vasculitis, large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. We divided different vasculitis and we will learn how the important vasculitis we have to remember for our exam. So my dear friends, large vessel vasculitis include temporal Takayasu, मीडियम वेसल इट इज पारस की कावासाकी वाइक, जो मेरे पास नहीं है बट इमेजिन कर लेते हैं, एक दिन तो आ ही जाएगी. ठीक है, चलो. पी फॉर पॉलीआर्थराइटिस नोडोसा, ठीक है. कावासाकी, लव यू नॉट, ओके, कावासाकी डिजीज. And B for Burgess disease. Then coming to the small vessel vasculitis, it is my way to Chandigarh. M for microscopic polyangiitis, Wegener's granulomatosis, Churg-Strauss syndrome, Hinoch-Schönlein-Purpura. Now let's talk about this Hinoch-Schönlein-Purpura first. In the Hinoch-Schönlein-Purpura, remember, let's talk about the important things right here. P. Anca. P. Anca is present in PCM. This table is like this, okay? P. Anca is present in PCM. P. Anca, Churg-Strauss, and M for microscopic polyangiitis. Very important to remember, sir. This is P. Anca, this is C. Anca. P. Anca is CM, that is Churg-Strauss and microscopic. C. Anca is present in Wegener's, ko we have converted to Wegener's. G is replaced by C. C for C. Anca, Wegener's granulomatosis, sir. Diagnosis of vasculitis by the biopsy we do. Okay, chalo. Antibodies and the biopsy. Treatment of vasculitis is steroid. This is gross treatment and gross diagnosis for everything. But the question is exceptions. So 3 exceptions with the different treatment we are having. Burgess disease, stop smoking, Kawasaki, IVIG, Wegener's granulomatosis, Wegener's we have talked, C. Anca, C for cyclophosphamide, C for cyclophosphamide. So all vasculitis diagnosed with the help of biopsy, antibodies. Yes, done, sir. All vasculitis treatment is steroid. But some exceptions are there. For example, Burgess disease, lifestyle modification is the best thing we can use. If there is a gangrene, we will debride it. If there is a Kawasaki, 𝗖𝗵 we have to give. Wagner's disease, we give the cyclophosphamide. These are the different things you have to keep adding on. Now, temporal arteritis or giant cell arteritis, this is small vessel vasculitis. Clinical feature, here the temporal artery is involved. We are taking biopsy from here, sir. Clinical feature, there will be facial pain, pain on chewing, headache, polymyalgia, temporal artery ka biopsy liya, and now the treatment is steroid by the rule of 60. Now, what is this rule of 60? Most commonly it is seen in the female more than 60 years. When on investigation ESR is more than 60, then you have to give a prednisolone, that is also 60 mg per day prednisolone. Next vasculitis is PAN, that is medium vessel vasculitis, polyarteritis nodosa. Now this condition is associated with type 3 hypersensitivity reaction. Now what is happening? It is involving all the organs except your lung. This is also very important. This is involving all the organs except your lungs. So you will say in the PAN, what you are having, the purple pruritic rash. Purple pruritic rash, you will take a biopsy and treatment is what, sir? Your steroid. Involve all the organs except your legs. Now coming to the Kawasaki disease. Kawasaki disease, see, Kawasaki disease, everything is RRR. How is this RRR? Red eyes, redness on the BCG scar, rash, irritability, fever, red tongue, then red palm. So everything is RRR in the Kawasaki. Treatment is IVIG. Initially we can give PCM and also interleukin-1 antagonist, that is anakinra drug also weak. But if someone is asking you about the treatment of choice in the Kawasaki, your answer is IVIG. So Kawasaki is simple, RRRRRR, and treatment is IVIG. IV immunoglobulins you have to give. Now coming on to the next one, sir. Chalo, Ch-Strauss syndrome. Ch-Strauss syndrome associated with asthma and eosinophilia. Sir, asthma and eosinophilia, you will see right here, sir. IgE may be increased. Plus Ch-Strauss में क्या देखने मिल रहा था? PCM pneumonic याद करा था, Ch-Strauss and microscopic polyangiitis. Now Ch-Strauss again treatment is steroid. Now hinoxaline purpura, a very important topic, sir. Hinoxaline purpura, most common vasculitis in children associated with IgA nephropathy. Palpable purple pruritic rash is present. Hematuria, diagnosis mostly clinical while seeing the pruritic purple rash in children. 90% self-limiting, but if it is not self-limiting, give the low dose steroid. Low dose. Hinoxaline purpura, most common vasculitis, IgA nephropathy से associated है, pruritic purple rash you are going to see, 90% self-limiting. This answer was asked in the exam. The what treatment you are going to give? One option was self-limiting, 90% wait and watch. And if someone is saying the person is waiting and watching, the symptoms from 1 year, 2 year not going, then you will add a low dose steroid, low dose steroid. Now coming to the vaginous granulomatosis. Vaginous granulomatosis, you are going to see CNK treatment is cyclophosphamide. What? Yes, IgA deposition is also seen. Vaginous के अंदर strawberry gums are seen. Nose के अंदर you will see a saddle nose. Important feature, my dear friends. ठीक है? Lungs के अंदर you will see the cavities. Strawberry gums, cavities, saddle nose. These are the typical feature. You are going to talk about the vaginous granulomatosis. Diagnosis is CNK and treatment is cyclophosphamide. Treatment is what, sir? Your cyclophosphamide. Now, Burgess disease or thromboangiitis obliterans, which is the other name of a Burgess disease. This Burgess disease, the history of young male smoker in which the artery, nerve, vein and the nerves are involved, but never the lymphatics. So what will happen? Your arterioles will become narrow, because of which gangrene will happen. So lifestyle modification include the stop smoking. Also, you can give the calcium channel blocker, etc. to dilate the vessel so that blood flow should be increased. And if there is a gangrene, you need to do amputation. Now, investigation right here in the Burgess disease is angiography to check the vessel status, and you will see a corkscrew appearance. You will see what's a corkscrew appearance. Now, coming to the next one is liver. Let's talk about the next topic in the pathology, and that is going to be the liver, which is the most common type of hepatitis, that is hepatitis A. In children also A, chronic is B, and most potential cause of chronic is C. Acute in adult is E, associated with pregnancy is E. Okay? Chalo. Now, acute versus chronic hepatitis. Acute के अंदर the duration is less than 6 months. Okay? And also you will see the Councilman bodies and hepatocytes. This Councilman body and hepatocytes are the feature of acute viral hepatitis, and chronic viral hepatitis more than 6 months. on the histopathology, remember on the histopathology, bridging fibrosis or ground glass hepatocytes are seen. So Councilman body will take you on the acute viral hepatitis, this bridging fibrosis, ground glass, they will tell you about the chronic viral hepatitis. Now marker of hepatitis B. So remember there is a antigen, okay, antigen, and there are the antibodies. If HBS antigen is there, that means स्वागत हो गया है. क्या हो गया? स्वागत. तो वायरस एंटर हो गया है. C मतलब कट गया है, नहीं दिख रहा है. E मतलब replication has started, infective phase is going on. Now antibody, if we talk about IgM and IgG. IgM is a marker of acute, IgG is a marker of chronic. Any question which is coming you to identify what type of this, always remember something which is IgM and Ig. Two option will be having an acute word written, two option will be having a chronic word written. If IgM is there, two chronic one, you will rule it out, you will choose answer between those two. That will become very easy to mark the answer. Now there is hepatitis E, that means end of infectivity. S means now safai ho gayi hai, it is cured. Now treatment of hepatitis B, if we have to talk about, sir, tenofovir, entecavir and lamivudine. Okay, so tenofovir, entecavir and lamivudine are the drugs we give, and treatment of hepatitis C is ladipasvir, sofosbuvir. There are some drugs you need to remember just before the exam as a revision part, my dear friends. Now biliary tract disorder, we are having primary biliary cirrhosis we are having, secondary biliary cirrhosis we are having, primary sclerosing cholangitis we are having. So primary biliary cirrhosis, if we talk about AMA, antimitochondrial antibodies, तो प्राइमरी बिलियरी सिरोसिस के अंदर क्या देखने मिलेगा? अम्मा देखने मिलेगी. ट्रीटमेंट में अर्सोडिऑक्सीकॉलिक एसिड, ट्रीटमेंट ऑफ चॉइसेस लेजर ट्रांसफर. सेकेंडरी बिलियरी क्रोसिस, ऑब्स्ट्रक्शन, ट्रीट द कॉज, ऑब्स्ट्रक्शन खत्म. प्राइमरी स्क्लेरोजिंग कोलिंजाइटिस लाइक PCM, here P is P anca, you will see, sir. Ursodeoxycholic acid, liver transplant, you will do, sir. Now coming on to the last part of the pathology which we are going to complete right now is hematology, and hematology for sure is going to give you at least 3 to 4 MCQ on the coming exam. So make sure you learn hematology very nicely. I'll spare maybe more 10 minutes to just you teach the hematology main crux. Chalo, let's start with the hematology. The most common type of blood group is ABO. Least common is Bombay phenotype. Safest is cross match, universal donor O, recipient AB. One line is that. Now pre-transfusion testing include for HIV, viral marker, hepatitis B, C, syphilis and malaria. We have to do it, sir. Now blood is divided into PRBC, which is stored at +4 degrees Celsius. This is given in acute blood loss and severe anemia, that is hemoglobin less than 7. Now platelet rich plasma is further divided into platelet and fresh frozen plasma. Platelet is stored at room temperature. Plate leke khana khate room mein. So these are done as stored at room temperature, and in thrombocytopenia, when dengue etc. low platelet count is then we give the platelets. Then fresh frozen plasma is stored at -18 degrees Celsius when we give that warfarin toxicity and A fibrinogens. When there is uncontrolled bleeding, in that also we will give the fresh frozen plasma, sir. So this is blood product divided into PRBC, one product PRBC, one is platelet, one is fresh frozen plasma. 3 of them having a storage temperature, equally important for the exam. Now blood transfusion notes also we have to include. What are the BT notes? Warm prior to the body. ठंडा गरम अंदर नहीं डालना है, बॉडी टेम्परेचर से मिला के थोड़े दिन बॉडी के पास रख के पेशेंट के, then you will transfuse it. Initially less drops, then if no hypersensitivity reaction you will observe, then you will increase the drop, that is 10 to 14 drops a minute. In case of a hypersensitivity, the number one thing you are going to do is stop the blood transfusion and injection AVIL and some steroid like dexamethasone you have to give the. If hypotension is given, give the ADR, that is your epinephrine. Done. ठीक है, चलो. Now coming to the WBC disorders. WBC disorder, we are having blood से क्या है? Leukemia, which is myeloid lymphoid having acute and chronic, AML, CML, ALL and CLL. चलो. और lymphoid से क्या है? Hodgkin's and non-Hodgkin's. Let's, my dear friends, talk about this topic. Hodgkin's, non-Hodgkin's, what you are going to see, types, treatment, same with the AML, CML, AL and CLL, sir. Coming on to the next topic, Hodgkin's lymphoma. Pay very kind attention to this topic, Hodgkin's lymphoma, my dear friends. Etiology of Hodgkin's lymphoma is Epstein-Barr virus. What they produce, this is just to remember, produce latent membrane protein, activate NF-kB pathway. Proliferation increase, Hodgkin's lymphoma happens. This is how it happens, but just remember, Hodgkin's lymphoma etiology is Epstein-Barr virus. What are the clinical features? Pale abstain fever, night sweat, weight loss, sir. Then painless cervical lymph node enlargement, symptom worsens with alcohol. These are the typical features of the Hodgkin's lymphoma. टीबी जैसे फीचर आ रहे हैं सर आपके एप्स्टीन बार वायरस के अंदर, इसके अंदर, ठीक है ना। पैल एप्स्टीन फीवर, बहुत ज़्यादा फीवर, नाइट स्वेट, वेट लॉस, सर्वाइकल, पेनलेस सर्वाइकल लिम्फोडेनोपैथी. ऑल्सो पेशेंट इज कंप्लेनिंग कि शराब पीने से सिम्टम वर्स होते हैं. नाउ यू विल सी व्हाट ऑन द हिस्टोपैथ एग्जामिनेशन in the Hodgkin's lymphoma and non-Hodgkin, both you will see the Reed-Steinberg cells. Both you will see the Reed-Steinberg cells. Now lacunar variant and the popcorn variant, two variants are there, sir. It is an empty space. Lacuna means empty space around. Empty space around. You can see very good lacunar cells are here. Lacunar cells are. This is lacunar cell. This is popcorn cells. Popcorn variant, which is associated with nodular lymphocytic predominant Hodgkin's lymphoma. This is this, and this is this one, sir. ठीक है, चले. Now coming to the types of Hodgkin's lymphoma. Type of Hodgkin's lymphoma, you will have a lymphocyte poor, lymphocyte rich, mixed cellularity, nodular sclerosis, and lymphocyte predominant. So lymphocyte poor is having the worst prognosis. Mixed cellularity is most common type of Hodgkin's lymphoma in India. Sir, nodular sclerosis is most common type in the world, and lymphocyte predominant is having the best prognosis. They are having what, sir? Best prognosis. Now, what are the treatment you are going to offer in the Hodgkin's lymphoma? The main part Hodgkin's lymphoma के types देख लिए. Lacunar type, popcorn type, other are lymphocyte poor, mixed cellularity, nodular, lymphocyte, पैल एप्स्टीन फीवर, एप्स्टीन बार वायरस से एसोसिएटेड है, वेट लॉस देखने मिलेगा, अल्कोहल के साथ सिम्टम वर्स होंगे. These all are features of a Hodgkin's lymphoma. Reed-Steinbergs are both for Hodgkin's and non-Hodgkin. Most probably it will be seen in the Hodgkin's lymphoma only. Now treatment regime for the Hodgkin's lymphoma is a mnemonic, that is ABVD. Adriamycin, bleomycin, vinblastine, dacarbazine. Adriamycin, bleomycin, vinblastine, and dacarbazine. This is a regime we are going to give in the case of a Hodgkin's lymphoma. Done and dusted, sir. Now coming to the non-Hodgkin's lymphoma, this is B cell and T cell associated. First of all, let's see the important which are B cell associated, my dear friends. If we talk about the B cell associated, the tumor marker are CD19 and CD20. Now the follicular cell lymphoma is the first one we have to talk about. Now here the cells are arranged in the follicles. In the histopath examination, you will see slide, there will be a follicles like this. You will see the follicular arrangement is seen. Now B cell T1418. Translocation is there on the T1418 and overexpression of BCL2 gene is seen, sir. तो follicular में दो चीजें important, एक उसका pattern important, दूसरा over gene expression किसका है, that is BCL2, then 14 and 18. Now Burkitt's lymphoma, second type of B cell associated non-Hodgkin's lymphoma is Burkitt. Burkitt के अंदर 𝗓-MYC gene overexpression plus 814, 814 translocation is there. Burkitt के अंदर biopsy पे you will see a starry sky appearance. Which appearance you are going to see? Starry sky appearance. Then coming to the diffuse large B cell lymphoma, dusty type of slide you are going to see. Most common and dangerous with the worst prognosis. यहाँ पे किसकी है? 𝗓-MYC gene translocation is there. Now coming to the fourth one is ventral cell lymphoma. Fourth one is what, sir? Your ventral cell lymphoma. It is seen in elderly, male more common than females. It is seen in elderly, male more common than female. Ventral के अंदर तो मेल के अंदर में है मेल ज़्यादा है फीमेल, ठीक है. नाउ सर मेल मेंटल कब होता है? रात को 11 बजे से लेके सुबह 2 बजे तक, जब वो जस्ट टू रिमेंबर, ठीक है. एंड देयर इज अ ओवर एक्सप्रेशन ऑफ साइक्लिन D1 जीन, ठीक है. इस टाइम वो दिल की बातें करता है 11 बजे से लेके सुबह 2 बजे तक, तो 11-14 इज गोइंग टू बी देयर, मेल के अंदर ज़्यादा होता है. देन कमिंग टू द हेरी सेल लिम्फोमा, सर हेरी सेल लिम्फोमा. Also you will see the cleaved cell right here, sir. Cleaved cell right here. Cleaved cell. फटे टूटे हुए cells you will see right here, sir. Now coming to the hairy cell lymphoma, it is TRAP positive. एक special stain आती है that is positive in this case. Plus hemoglobin, TLC, platelet counts are less in this. Hemoglobin भी कम, TLC भी कम, platelet भी कम. And on examination you will see the hairy cells. ठीक है. hairy cells are seen. Now on biopsy, you will see a honeycomb appearance or fried egg appearance. These hairy cells are also looking a honeycomb appearance type also. Now the treatment is cladribine. तो बाल को सहलाते हुए कॉल कर रहे हो, cladribine is going to be the treatment. Cladribine is going to be the treatment. Now sir, T cell है तो 5 type of B cell associated we have just learned sir. Can you please bother to answer my questions, my dear friends? My first question is, which gene overexpression is seen in follicular type? Follicular type lymphoma. Can you tell me? Number one, which gene is overexpressed in the follicular type, sir? BCL2, BCL2. Very good. Burkitt's के अंदर कौन से ट्रांसलोकेशन होता है? Can you tell me translocation in the Burkitt's lymphoma? Which translocation is there in the Burkitt's lymphoma, sir? 8-14. Very, very good. Very, very good. Sir, which is a trap positive? Where honeycomb appearance is there, where hairy cells are seen, trap positive, sir. Which one is trap positive? Hairy cell lymphoma. Very good. It is hairy cell lymphoma. Hairy cell lymphoma. Very, very nice. Very, very nice. Now moving on to the next one, sir. T cell associated adult T cell and mycosis fungoides, which is also Sézary cell syndrome, not a fungal infection, just you will see a Sézary cell. Now adult T cell where HTLV1 is there, you will see a flower shaped cell. Flower shaped cell. Okay? Flower shaped cell, sir. By HTLV1 human T cell leukemia virus, you will see a flower. So these are the 2 variants in the T cells and 5 in the B cells you have to remember for your exam. Now coming on to the next one, sir. Third one, anaplastic large T cell lymphoma, another added to the T cell one only. ALK gene mutation on the chromosome number 2p. Hallmark cells are seen. Classification for lymphoma is real classification. Staging is an Arbor method. Treatment of non-Hodgkin's lymphoma is R-CHOP. ABVD was treatment for Hodgkin's lymphoma. R-CHOP is a regime for the non-Hodgkin's lymphoma. Rituximab, cyclophosphamide, hydroxyduanorubicin, oncovin and prednisolone. Oncovin and prednisolone, my dear friends. Now coming to the myeloid disorder, and myeloid disorder is CML, AML, ALL and CML. What other things you have to see right here in this? So if we talk about the CML, the clinical feature is hepatosplenomegaly. There is a Philadelphia chromosome where the balanced translocation is seen at 922. Now ABL-BCR gene is getting activated, which will further activate tyrosine kinase and which will lead to the proliferation, that is cancer. To block this tyrosine kinase, we are having a drug of choice used in CML, that is your imatinib. So imatinib is a drug of choice in case of a CML, sir. CML, sir. Thank you. Now coming to the next one. Lab diagnosis. Hemoglobin is normal, rest everything is increased. Bone marrow biopsy mein CML mein what you are going to see? Garden party appearance. This is garden party appearance, college girl appearance, garden party appearance. Okay? Now coming to the AML. Acute myeloid leukemia. Now intracytoplasmic rod or rods are present. Dye is myeloperoxisome. Okay? Chalo. Sudan black dye. Most common type is M2, most significant M3. Where translocation is T1517. Where the translocation is what, sir? T1517. And gingival infiltration is seen with M5. Gingival infiltration is seen with M5. And treatment to this is bone marrow transplant. The OR rods is associated with, that is AML, gingival infiltrate, most common type, significant type where the translocation 1517 is seen. Those are AML wala part. Now coming to the CLL. CLL, एक CLL की बात करेंगे, रिचिटर ट्रांसफॉर्मेशन. CLL के पास में रिचिटर ट्रांसफॉर्मेशन होता है which can convert this into DLBCL, diffuse large B cell lymphoma, most severe, most common. कॉल पे बात करते हैं elderly और adult, और कैसी आवाज आती है? आहा. तो remember it is associated with AHA, that is autoimmune hemolytic anemia. Autoimmune hemolytic anemia. Hemolytic anemia. हाँ, M7 is for down. Yes, M7 is for Downs. Down syndrome. Very good. Now coming to the histopaths, smudge, parachute or basket cell, you can write C here. Drug of choice is fludarabine. Periodic follow up for PET scan so that metastasis check करी जा सके. That will do, sir. Now coming to the last one is ALL. बच्चे सबको पसंद है. एक बच्चा जो है most common होता है. 3 हो जाए तो worse prognosis है associated with the Down syndrome. Now you will see like there's a kind of a coconut type of cells you are going to see right here. Treatment is 𝗲𝗲. So 𝗲𝗲 is vincristine, asparginase, prednisolone, doxorubicin, and here treatment of choice is again a bone marrow transplant. Bone marrow transplant. The four things we have studied right here, sir. What are the four important things we have studied right here? One is CML, another is AML. If I talk about the college girl appearance, what answer you are going to give me? College girl appearance is seen in CML. CML. Very good, very good, very good. Sir, basket cell are seen in CLL. Very good. Coconut cells are seen in ALL. ALL. Very, very good. Very, very good. Now we are going to hematopoiesis. थर्ड वीक, थर्ड मंथ, फोर्थ मंथ में क्या होता है? योग सैक में होती है, फिर लिवर में, फिर बोन मैरो लिवर दोनों में होती है. जस्ट बिफोर द बट इट इज ओनली इन द बोन मैरो. नाउ हेमाटोपोइटिक स्टेम सेल्स, यू विल सी द lymphocyte and the myeloblast. Lymphocyte we are having T lymphocyte, B lymphocyte and natural killer cell. And in case of a myeloblast we are having erythroblast. Erythro is sounding like a R. It is an immature cell and it gives rise to a mature cell called as RBC. मेगा प्लेट में खाना लाई तो मेगा कैरियोब्लास्ट इज योर प्लेटलेट. माइलो मिलो, किससे मिलो? एनबी वालों से मिलो, पासिंग सर्टिफिकेट लेके आओ. दैट इज योर न्यूट्रोफिल्स, बेसोफिल एंड इओसिनोफिल. Our all content is for FMGE and NEET PG both and other exams also. Now this monoblast, monocyte, then it will convert to macrophages. These are the lymphocyte origin cells and the myelocyte origin cells. Now let's type of anemia. Let's talk about this is iron deficiency anemia. Iron deficiency anemia is the most common type of anemia. That means iron in the blood is transported by transferrin. Iron stored in the blood in the form of ferritin, teen के डब्बे में. And iron is absorbed in the duodenum by the DMT transporters. ठीक है? Divalent metabolic transporters. Now what happens in this iron profile if you do? TIBC and free erythropoietin porphyrin. They both are high, rest everything is low. First thing is this, iron deficiency anemia mein, these both things are high, rest everything is low. This is iron deficiency anemia. Cause dietary, excessive blood loss can also lead to. And also on the peripheral smear you will see microcytic hypochromic cells. Microcytic hypochromic cells, which are pencil shaped cell. Yes, these are pencil shaped cell. Feature is cholionychia. You will see the spooning of the nail. This is called as cholionychia. Also you will see the chiliosis, inflammation of your side lip. If hemoglobin is less than 7, PRBC will give, not RP. This is PRBC. Okay, PRBC. If hemoglobin is more than 7, orally you can give ferrous sulfate and IV you can give ferrous sucrose या फिर carboxymaltose या फिर carboxymaltose. Now sideroblastic anemia is a triple S, you have to remember. S for sideroblastic, S for serum iron, serum ferritin will be high, rest everything will be low. And on the peripheral smear you are going to the basophilic stippling, and basophilic stippling can be because of the lead poisoning and iron overload also. Treatment is bone marrow transplant. Then coming to the next one, AOCD. AOCD is anemia of chronic disease. Now there is a chronic inflammation which will lead to the activation of macrophage, and macrophage will further activate hepcidin. Hepcidin will lock the iron within the store. So stored iron is in the form of ferritin. So teen will be high, rest everything be low. So ferritin, serum ferritin will be high, rest everything will be low. So what is the cause? Cause is chronic inflammation. So we will treat the cause and we'll come to the conclusion. We'll come to know the conclusions. Done? Coming on to the thalassemia, beta thalassemia. There's a beta chain defect. Minor, no treatment. Intermediate, blood transfused every 3 to 6 months. Major, blood transfusion every month. MCV is low. MCV upon RBC will give you Menzer index, which is low in case of a beta thalassemia. Peripheral smear you will see are teardrop cells and target cells in the beta thalassemia. Plus clinical feature में crew cut appearance, which is a feature of both beta thalassemia and sickle cell anemia. Both of them you will see this. Plus additional to this, in the beta thalassemia you will see a chipmunk faces. What you will see is a chipmunk faces. Now sickle cell anemia. What is happening in the sickle cell anemia? Your glutamic acid is replaced by valine at the 6th position of the beta globulin chain. And here you will see a crew cut appearance or head appearance. Also you will see the sickle cell. This sickle cell will do what? They will cut the spleen. So this is called a splenectomy, autosplenectomy. So what will happen? Autosplenectomy. So after splenectomy, which bodies you are going to see? This is called as Howell-Jolly body. क्या बोलेंगे इसको? Howell-Jolly body. Then another type of anemia is G6PD deficiency anemia. When there is a G6PD deficiency, there is an oxidative damage to the RBCs. So what you are going to see? Heinz body and bite cell. Heinz body and bite cell. Then coming to the autoimmune hemolytic anemia. It is associated with CLL. CLL. Where you CLL में कौन से cell देखने मिले थे आपको? Hair cell, basket cell. Those all cells were seen right there. ठीक है sir? Yes. चलिए. Diagnosis में will do a Coombs test, treatment में steroid, IVIG. If not, then do a splenectomy. Now megaloblastic anemia causes vitamin B12 deficiency. Other causes can be pernicious, anemia, pancreatitis. One syndrome is there, Ehlers-Danlos box syndrome, sir. Now megaloblastic anemia is divided into two. One is folic acid deficiency and vitamin B12 deficiency. Now here you will see that MCB is more than 100 in both of them. Sir, there are two tests you have to remember, and also neurological deficient is present in folic acid, which is vitamin B9. It is absent with vitamin B12. Absent with B12. Now Figlu test is something which we do for F folic acid, and Schilling test is something we do for the vitamin B12 ka deficiency. Now the last one is aplastic anemia, sir. Aplastic anemia. My dear friends, this aplastic anemia where the hematopoietic stem cells are lost. And if hematopoietic stem cells are lost, only you are going to see the fat cell. If fat cells are dominating, that means aplastic anemia in which RBC, WBC and platelet all three are less. ये तीनों के तीनों कम हो जाते हैं. जब ये तीनों के तीनों कम हो जाते हैं तो remember how you are going to treat. If RBC are less, first of all drug treatment, otherwise bone marrow transplant and blood transfusion is other method. But we will RBC बढ़ाने के लिए darbepoetin E point, arbopoetin D point, platelet बढ़ाने के ultramopoetin, WBC बढ़ाने के filgrastim and sagramosin. These are the drugs you need to remember.